This is a patient that was referred to me who had a full thickness corneal graft over 20 years ago and unfortunately developed endothelial failure as well as cataract. Generally, I would perform DMEK in these cases to improve the ocular surface. That will allow me a better measurement for when we need to do cataract surgery. Visual debridement is performed using Spears and Tooks knife to improve the visibility. I usually perform 3 paracentesis and one main incision using a 2.2 keratome temporarily. The 2.2 millimeter incision is usually extended to about 2.8 when we need to insert the graft. Here I'm using anti-camera pilocarpine, but it can be used preoperatively as well. The desmoid is performed the usual way using scorer and scraper. I use it. I do perform desmoid with the help of the BSS. This is the vision tool I'm using to allow me to visualize any remaining remnant of the desmoid membrane. I use the micro forceps to remove these residual, which will clearly affect the attachment of the graft. The previous graft is about 7.5 millimeter, and I'm using a true find of 7 millimeter. This will allow me a good clearance and reduce the chance of graft detachment post-operatively. This is the main incision with using 2.2 millimeter keratome. Before I insert the graft, I try to orient the graft with the stromal side up, using the irrigation bolt to inflate the interior chamber. And here you will notice that the graft is delivered in a very controlled fashion. I use a technique where I generally rotate the plunger clockwise while pushing ever so slightly. This allows more controlled delivery of the graft. And when I do that, I slowly withdraw the golder tip. Now I'm just slightly inflating the chamber. As you can see, the graft is trying to orient in a taco fashion, which is quite difficult to unfold. Hence, I'm re-inflating the interior chamber. In this particular case, the graft automatically went into a double scroll position, which is usually very easy to unfold. But sometimes if it doesn't, you just have to keep rotating the graft until it orients itself in a more recognizable fashion. The DMEK lenticle is now well within the previous full thickness graft, and the F mark show that it is in the correct orientation, which is the stromal side up. I use a grabo cannula to deliver SF6 into the interior chamber, and I have a full fill for about 10 minutes, and leaving 90% afterwards. Patient are usually seen in about an hour's time for IUP check. This is 2 weeks post-op picture. You can see the cornea is already clearing up. There was unfortunately a small detachment for which I have to perform a rebubbling, and the corneal thickness actually improved from 923 microns to 560 microns within 2 weeks of the initial procedure.